Hello, everyone, and thank you so much for joining us. This is Bethany O'Connor from Health Policy Plus. I am delighted to welcome you to today's webinar entitled Health Sector Decentralization, Can It Still Deliver? We have a great broadcast for you today, and we'll begin with just a few announcements. Next slide, please. This session is being recorded, and we will post the recording to the HP Plus webinars page. We would love to hear from you, and we welcome your questions at any time. Please submit your questions via the chat box on the right-hand side of your screen, and I will read them aloud when we pause for questions, or rather, our moderator will, excuse me. These web conferencing platforms are getting an unusual amount of traffic, so we ask that you bear with us in case there are any glitches with the technology. Finally, we ask that if you're not speaking, that you please mute yourself to keep the line nice and quiet while others are talking. And that concludes the House Rules portion, and I'll now turn it over to our moderator, Arin Dutta. Arin?
Thank you so much, Bethany. Good morning and good afternoon, wherever you are. My name is Arin Dutta. I'm the Senior Technical Director for Health Financing on the Health Policy Plus project, and I'll be moderating today's webinar. I'll actually come back later to take your questions, but first I'll also moderate a panel of questions for the presenters. So decentralization is a perennial topic in health system governance, and it's been pushed into focus with COVID-19, especially around questions related to where best to concentrate resources, how to plan, steward, and finance a response. And we'll have 3 presentations for you today and a moderated panel discussion. And as I said, we'll open up to your questions shortly after. It's my pleasure to introduce the panel for today. Our first speaker, Meral Karan, is currently working in USAID's Center of Excellence on Democracy, Human Rights, and Governance. She specializes in government institutional reform with a focus in local government, public administration, and economic governance. She most recently served with USAID in Malawi, supporting broad decentralization efforts there, but has also worked in Serbia, Azerbaijan, Nigeria, and Egypt, among other places. Next, Palladium staff Jorge Ugas will be presenting the Indonesia case. He's a senior technical advisor specializing in health economics, and he's been working with us since 2019. Before that, he was a senior researcher doing impact evaluation of international projects with Mathematica and Apt Associates, and he is originally from Peru and has been a consultant for the Inter-American Development Bank and the PAHO organization. After him, presenting the Kenya case, our country director from the HP Plus Kenya and East Africa program, Stephen Mushiri. Stephen Mushiri joined us in 2012, and before that he worked for Apt Associates and supported several countries in Africa on health financing initiatives. He has served the government of Kenya in various capacities, including with the Ministry of Economic Planning, the Ministry of Health, and the Office of the President, and has played key roles in several central planning units. Specifically, Stephen also served as the Chief Economist for the Ministry of Health, overseeing the Policy and Planning Division. And finally, our discussant for the moderated panel discussion is Alison Lipsky, who is the Health Policy Plus Project's technical lead for accountability and stewardship, and also senior manager in RTI International's Global Health Division. She has expertise in strengthening accountability and its enabling environment, especially within the context of decentralization. She also works on social accountability for universal health coverage and family planning. She's been with the project since 2015 and has vast experience working across Africa and Asia. So we'll have a very good panel discussion a little bit later. But first, we'll begin with Meral, who will help to frame decentralization for us. Meral, please go ahead. Thanks.
Thank you so much. Good morning, good afternoon, good evening to all of you, depending on where you're coming from. So as Arin mentioned, faced with considerable challenges in the many countries we work in, made more striking by COVID, many of us are reasonably asking what role governance plays, notably decentralization, in addressing health outcomes. Can decentralization deliver? And if so, what does it really take to get us there? So in the next 5 or so minutes, I will just make some general remarks so as we collectively chew on these issues through this panel. So next slide, please. So as we know, decentralization takes many forms as central government shifts power and resources to elected or appointed subnational units. However, regardless of the form, nearly all countries decentralize to some degree and for varied reasons. Usually the decision to decentralize is a political one, either out of a drive to bring decision-making closer to communities, to improve accountable and responsive governance, or for issues of stability related to power sharing or giving a particular area of the country more autonomy. However, decentralization isn't a simple act. It's a massive restructuring of government. So while decentralization often happens through a political process and often through maybe a general law, it requires careful, detailed planning and structural changes across political, financial, and administrative levels. I'll get to those issues in a minute, but suffice it to say, the level of planning, detailed regulatory changes, capacity building, and the central local government support often aren't completed. In such a situation, it's not surprising there are functional gaps. You often hear of countries that have been decentralizing for decades, for example, and it just shows the challenge of implementing an actual decentralization policy. So the first obvious point is that the overall plan for a decentralized system must be methodically thought out and adjusted over time. It must be designed to function. So a first port of call for all of us should often be just to understand why a country is decentralizing, what powers exist, and what the current plan or momentum to complete the reforms really is. Next slide, please. So I find that sometimes the terminology and the way we discuss decentralization can imply a dichotomy or preference between central government or local government. So it's important to understand that having a decentralized system doesn't take central government off the hook or diminish it somehow. Decentralization is about allocating those responsibilities to the level that best can manage them, to the lowest level that can best manage them. To have strong local governments, you do need a strong central government as an important partner, but most importantly, you need them to work well together. Intergovernmental relations is a critical area of focus which is often left out of our discussion. And research shows that successful local service delivery is driven by multi-layer governance and strong intergovernmental coordination. So it's not an either or versus kind of conversation. It's really about and. In my view, more focus needs to be on the intergovernmental communications, planning, and operations than is often the case. This is clearly necessary in the current COVID experience, but it holds true in normal operating times as well. Next slide, please. So we know that it needs to be designed to function and that different levels of government matter and should coordinate. But how should a good decentralized system specifically look? Well, obviously that's a trick question because it depends. But decentralization generally has three interlocking pillars: the political, fiscal, and administrative levels. Each is profoundly important in their own right, and it's important to understand that if there is insufficient authority or capacity for one of these, the system simply doesn't function as intended. It's like one short leg on a stool. My observation has been that we often, particularly in the health sector, focus on local policy, budget, planning issues. Fiscal decentralization is often particularly of concern, health financing, for example, and rightfully so. However, I would argue that is possibly a little more straightforward of an issue to address, as it usually involves a mix of central transfers and increasing authority of local governments to raise revenues and manage expenditures. I'm not suggesting it's easy, but it's a little bit more consistent across countries of how you get there. A possibly thornier or overlooked issue, and one that I think often affects health outcomes, relates to administrative decentralization, notably the decisions around human resources, health workers, and performance management. In order to deliver accountable and community responsive healthcare, local governments need some authority to manage the health workforce, which is responsible for delivering on the targets set by the center, as well as the local demands for improved quality. However, often local governments are unable to recruit, even if they have sufficient funds, for the categories of labor that are most needed. Performance management is often functionally non-existent, and supervisors have limited ability to incentivize, promote, or sanction workers. Simply put, local governments and facilities can do very little about issues like absenteeism or underperformance if there are limited consequences or incentives that they can instill. When performance management is dependent only upon central government, or where communications is weak between local and central levels, often good performers simply lose motivation and poor performers are either left as they are or at best transferred, which, let's face it, just kind of makes it someone else's problem. However, these raise large civil service questions. What should be devolved? Is there capacity to manage recruitment, retention, performance management? What about maintaining consistency and skills in hiring if hiring becomes devolved? And how do you avoid a proliferation of hiring that can lead to a massive uptick in national debt? So I don't claim the devolution of the health workforce is the solution, but simply that more thought around human resources and performance management between central and local levels seems warranted. And it's key to helping local governments and facilities improve performance and meet quality standards. It also points back to my earlier point that addressing intergovernmental issues is important. So in addition to working with the Ministry of Health or the local governments, it can help to engage Ministry of Labor, civil service directorates, as well as labor unions, which are all important actors to address workforce performance and human resources issues. Next slide. So all this is well and good, but there is still one more consideration I'd like to raise. If some decentralization is generally good, more of it isn't necessarily better. There isn't a specific rule, but there's a growing consensus that countries have a sweet spot between providing sufficient local autonomy and retaining economies of scale and bureaucratic efficiency. Many countries are examining that balance now and may be discovering that their core challenge was to decentralize too much to too small of units. Then some functions perhaps should not be devolved at all, such as supply chain procurement, depending on the context. Next slide, please. So that is just a few general thoughts I wanted to share about sort of overall context, and happy to engage more in the specifics during questions at the end if you have any questions. Thanks so much. And now I'd like to hand it over to our next speaker, Jorge Ugaz, for the HP Plus in Indonesia. Jorge?
Yes, thank you so much, Meryl. Good morning, everybody. What a pleasure to be here with all of you today. My name is Jorge Ugaz, and I want to talk about the experience here in Indonesia, and I'm presenting instead of my colleague, Cristina Yarrow. Next slide, please. So HP Plus has been working with the government of Indonesia since the year 2015 with the intention of generating evidence and developing government and key stakeholder capacity to sustainably finance and equitably provide healthcare services. Our support to the government of Indonesia takes place at intervals all along the policy cycle that you can see here on the right. Although I must say, this graphic, I think, makes it look terribly simple, easy to understand, even logical. But I must confess that policymaking in Indonesia can be and get incredibly complex and messy, which makes actually the work a little bit very exciting. We're currently focusing on maternal and newborn health and also on the HIV clinical areas. Those are the two top priorities for USAID Indonesia. HP Plus is also deeply committed to supporting the government to more efficiently and effectively finance the health sector. We have been costing medium-term development plans. We've launched strategic purchasing agendas in MNH and HIV. We have been also costing national and subnational responses to HIV as part of the GOI's ambitious acceleration plan, etc. And key for the next year or so, we're focusing on advancing private sector engagement, which is a priority for the government as they look to leverage other sources of funding to achieve its health sector objectives. Next slide, please. In Indonesia, decentralization has transferred substantial power to provinces and districts in a very short period. Some sort of like a big bang decentralization, as we call it, unlike what we have seen in other similar countries in the region, such as Vietnam and the Philippines. And over time, more autonomy and resources have effectively been assigned to local level governments. In 1999, health services were decentralized to province and district levels. Planning for and managing of service delivery fell to local governments. In 2014, the National Social Security Law came into effect, paving effectively the way for the universal health coverage debate. And along this timeline, we see the government sort of like acknowledging the need for adjustments, more clearly trying to delineate between central and subnational and the provincial and district level responsibilities. The regulations in 2007 and 2014 further stipulated those responsibilities at the local level. It got actually quite interesting also on the top right when the government of Indonesia issued the Ministry of Health regulation that outlined the minimum services standards in the health sector, or as we call them in the Bahasa acronym SPM. And we'll talk about SPM in a couple of minutes. Next slide, please. Here we look at some recent figures on fiscal decentralization. What we see is that the total central transfers to provinces and districts have slightly increased over time, over the last 5 years. The share of the social health insurance has also increased over time. That's the yellow band that you see on the graph on the left. And out-of-pocket expenditures have been decreasing also over time. And as we know, this is a key step in reducing catastrophic expenditures that sometimes force households into poverty. And on the right, we see the 3 major transfer mechanisms to local government. These are the DAU, the DAC, and the DBH. Of these, I'm just going to say one thing about the DAC. DAC is the one that has sector-specific allocations, including for health. It's the second largest source within the transfers to the sector. It has had district proposals related to it, and yet at the same time, it still has limited capacity at the district level to generate high-quality, evidence-based proposals. Next slide, please. Look at how complex this is. So this is sort of like our simplified flow of funds diagram for the health sector. This is actually a simplified graphic. This is the graphic for the PowerPoint presentation. The original has approximately it's double the amount of the components that we see here. In Indonesia, health services provided in public facilities are financed by many financial transfer mechanisms. These flow from the national to subnational governments and are often earmarked for specific health-related expenditures. Those can be infrastructure, health worker salaries, prevention and promotion programs, etc. And as this graphic shows, public facilities receive funds from at least 6 different provider payment mechanisms, including from local budget allocations and also for salaries. Other payment mechanisms include those in which social health insurance agency pays provider using capitation, non-capitation fees, Indonesian case-based groups, etc. And let's also not forget that facilities have the capacity to receive private funds through out-of-pocket payments and also through contracted private insurers. It's important to note and for us to understand that the majority of the transfer that I just mentioned are not performance-based. Next slide, please. So we see that the government has instituted a myriad of funding transfer mechanisms, and yet Indonesia has set very ambitious targets for itself that can be seen here on this table. And we know now, because of the work that we have been doing costing the implementation plans, we know that the costs associated with reaching these targets are expected to significantly increase. And a couple of very important things that I wanted to share as well is that as of now, the local government is not adequately equipped to use data and evidence to identify local problems, to identify priority setting or resource allocation. Overall, at the subnational level, they're still very reliant on central government in managing resources and delivering basic services to the people. Also, the central government to date has not instituted rewards for high quality service delivery or for efficiency. There is some incentive component to the transfers, but overall there is a lack of focus on the performance of subnational governments. Next slide, please. So here I wanted to spend a couple of minutes talking about SPM. SPM, as I mentioned a couple of minutes ago, these are the minimum service standards that I just mentioned. And SPM is one piece of a much larger puzzle, and I'm going to use them as an example. Decentralization in Indonesia is been sort of like an effort to address different dynamics between a powerful center and a disempowered periphery. And SPM is a crucial attempt to better incentivize local governments to do more. So initially, the GOI, they introduced SPM to standardize local spending and performance on social sector. They started implementing this in non-health areas, but the process of SPM started in health areas in the year 2017 as a way to reassert some level of scrutiny in spending. And the idea was to improve the quality of spending by linking it to specific indicators. And they instituted 12 indicators, and those are the ones that you can see on your right, across the life cycle, and also on communicable diseases and non-communicable diseases. And they each include standards on quality of materials and types of services provided, on quantity and quality of health workers providing the services, and they serve as a technical guideline also on how to deliver services. And although recent regulations paved the way for the SPM mechanism to incentivize good performance and sanction for good performance, in practice this doesn't happen yet. Next slide, please. So USAID support through HP Plus is leveraging SPM to strengthen decentralization in the health sector, working with the Ministry of Home Affairs, with MOH, with Ministry of Finance. And the focus of HP Plus, the approach of HP Plus has been to strengthen the administrative decentralization by making substantial revision to the current budgeting tools, creating an e-learning module to train and develop the capacity of thousands of civil servants across the country, and also developing a monitoring and evaluation platform to address, this is actually what Meral was mentioning, the lack of interoperability between ministries and between different levels of governments. Next slide, please. So do we have a diagnosis on where Indonesia stands in terms of decentralization? Well, we can say that indeed a few things have worked. The level of autonomy in spending and funding has improved. Transfers have increased. We have the implementation in 2017 of SPM as a standardizing mechanism for service delivery. The GOI has laws and regulations on paper that pave the way for more complete implementation of decentralization, at least that's on paper. And lastly, we have seen growing recognition and interest by the government, but MOH, but MOF, and other ministries that health services must be purchased more strategically. And this is a substantial undertaking since it involves the benefits package, how providers are paid, who provides the services, etc. And of course, some challenges remain, right? There's still significant differences between budget estimates and actual expenditures, which usually reflects inefficiencies in budget planning and execution. There are funding challenges, local revenue generation must be increased. There are also fiscal transfer challenges, and of course, administrative challenges, harmonization between SPM target and vision setting and the level of supply side resources that are available. We would like to see improved transparency, priority setting, just to name a few. And of course, now we have COVID, which is causing the government to reverse some level of autonomy because local governments do not have the capacity to spend sufficiently or efficiently enough. I think that this pandemic is forcing us to restart the clock, daring us to innovate, but also to redefine success. So can decentralization deliver for Indonesia? Sure it can. HP Plus work, I think, is on the right direction, but more needs to be done. Channeling more funding to be executed at a local level for health, coupled with making that spending more effective to deliver more health for the money. I think that those will be good, strong ways to start towards taking advantage of this sort of like window of opportunity that we have now on these challenging times. So thank you for your time. I'm going to stop here, and I'm going to pass the microphone to my colleague, Stephen Mushiri. Stephen?
Good morning, good afternoon. It is now almost a decade since Kenya adopted a new devolved level of government. And we want to share with you how the country managed this complex transition and some of the lessons learned. Next, please. In terms of what we do in Kenya, we have got two primary objectives. One is increasing domestic resource mobilization for Kenya health sector, both at national and county level. And we also strengthen the national and county linkages to enhance health finance policy and governance. And the map that is on the right shows the counties where we focus on. Next, please. If you look at the decentralization in Kenya, it started way back in 1963. It has been a long journey. It has taken three distinct phases. Phase one, between 1963-65, this was a federal government system on what is commonly known as Majibo. Then we went to unitary government system, 1965 to 2013. And then in 2013, after the 2010 constitution, we devolved to 47 counties, and we'll be discussing more on that in the next slide. Next, please. Looking at the Kenya's decentralization strategy, the 2010 constitution created two equal governing bodies. These bodies were distinct and interdependent. One of those bodies was national government, and then we had 47 county governments. As per the Schedule 4 of the Constitution, the responsibilities of the national government was to do policy and financial budget, where counties were supposed to deliver services, including health, agriculture, and rural roads. In terms of how the funding was split between national county governments, the county government was supposed to get 15% of the government revenue, and equally 0.5% of government revenue as equalization fund for selected counties which were before considered to be marginalized, and the rest of the funding was supposed to remain with the national government. We have seen funding the counties increasing since 2013. We are now at about 35% of the revenue, with the balance remaining with the national government to support primarily non-devolved functions, including education and defense. Next, please. Looking at how the devolution was planned after 2013, we had two phases. Phase one was to look at how do we unbundle the functions, cost those functions, and assign those functions to both either national county government and build the capacity of the counties to be able to take over those functions with minimal disruptions. And then phase two, from 2016 to 2018, was supposed to transfer the functions to from national government to the county government once counties were ready. But what happened is that immediately after the March 2013 elections, there was a push from the governors in July 2013, where governors was pushing for national government to let it go. And of course, with that push, the national government said, you can have it. And the focus of that push was give us the money. So governors were looking for the money as opposed to what has been devolved. And when this happened with minimal structure to support devolution, especially for human resource, for health, there were no structures to be able to take up those people who were before managed by the center. And because of that, there were disruptions of services, especially in health. There were strikes in most counties. And I think we saw some decline in health indicators because of those disruptions. But essentially, it was a two-phase approach, which was supposed to be managed by transition authority, and the crafters of the constitution had foreseen that those 5 years are good enough to be able to transition, but the big bang came up in July 2013. Next, please. Looking at the financing flow at the county level, I think if you look at the box, the square, the box at the center, the county treasury, all the funding that is going to the counties as per the Public Financial Management Act is supposed to go to county revenue account. And I think you can, if you look at, you can track what is going in, and sometimes there's opaqueness on what is coming out. And the casualty of some of those opaqueness is that health occasionally does not get its own funding. And I think this is an issue that under the revised Public Financial Management Act, I think they are trying to address to ensure that you can be able to see what is going in and what is going out, to ensure that all devolved functions are able to get the funding allocated to them. Next, please. In terms of our support to devolution in health, our primary support was build capacity in planning and budgeting, focusing on program-based budgeting or PBB. And we had 3 approaches. The first approach was to train county health management teams and build a team of trainers who would cascade this PBB training to the sub-counties. We built a lot of evidence to inform advocacy, especially with the county assembly teams, to be able to increase more funding to their sector, and mentorship, which was continuous to ensure that as more teams come on board, we're able to mentor them on PBB. And to ensure sustainability of our approach, we went ahead to establish the county health planning teams in the counties that we are supporting to ensure that we have got a team that can be able to drive the agenda of planning and budgeting in the health sector at the county level. Some results that we are seeing is that in the counties that we were focusing on, 26 initially, and now 14, is that they have all adopted a PBB, whose focus was linking resources to outcomes. We are seeing increased allocations in those counties at about 24% from 2015-16 to 2018-19. And we are seeing them prioritizing key programs, creating some program for HIV/AIDS, and allocating about $10 million in the last three fiscal years. And in 2018-19, we saw counties creating a reproductive health program and allocating about $4.4 million to support that program. This is a success because initially, at the initial stage of devolution, counties, felt that HIVs, LIH programs were national government functions, and the fact that we are seeing them prioritizing this funding is good for sustainability as we move towards devolution. Next, please. In terms of Kenya's current political and fiscal decentralization, I think we are seeing a linkage between the two, but it's incomplete. Progress made so far, there's some autonomy in terms of spending. Counties have been given autonomy to spend whatever have been allocated through shareable revenue. Expenditures on health in counties have been increasing, which is good. This fiscal transfer processes improving, although there are limitations because of the Public Financial Management Acts. We have got stronger regulatory environment to allow complete decentralization, and counties are creating planning structures to be able to drive the agenda on planning and budgeting at the county level. However, some challenges still remain, and I'll mention just a few. The capacity is still ineffective on planning, resource allocation, and spending, and more important, developing evidence to inform advocacy. There are funding challenges because functions were not costed, so counties never got exactly what they required to be able to support the devolved function. Procurement still remains an issue. Strategic commodities are procured through national government. Others are procured through the counties. HRIH management remains an issue. We have got the consultant still being discussed on who manages the consultants, and we have complicated and misunderstood accountability relationship. Because of these challenges, there are now discussions on reviewing or relooking at the 2010 Constitution. Both politicians, technicians are relooking at it. We have a report which should be published maybe the next maybe 1 month or so. Some of the recommendations we are hearing is that they want to centralize back human resource to the center. They want to expand the top to accommodate more leadership. We'll be sharing with you once we get a picture of what the report is contained, we'll be sharing with you on the next iteration of the constitution review. But we hope that even as we do so, there'll be no interruption on health services. I think that's what I wanted to share with you. We'll be discussing more during the Q&A. Thank you.
Thank you so much, Stephen, and also thank you to the presenters. So now we'll begin a short moderated discussion, but I just want to remind all our attendees that you can conceive of your questions and enter them into the questions box at any time, and we'll be reviewing them and picking them up very shortly to pose to the presenters. So in getting this discussion started, I mean, it's been fascinating hearing both the cases, and also it seems that both countries will be very shortly doing some form of review of decentralization In Indonesia, this is broadly speaking a review of fiscal transfers to the local level, which may have been paused by COVID-19, but is certainly at the center of everyone's thinking about how to make local government work better. So in this context, Mashiri, maybe if I may start with you. I had a question around an issue that was brought up by Miral. So decentralization is clearly intended to improve health service delivery and empower decentralized governments. But in both cases today, there is some mismatch of assignment of authority and assignment of resources at different levels of severity. So for Kenya, do you think that the resources and the authorities that have been decentralized so far more or less reflect where county administrative and technical capacities are, thinking of administrative decentralization as that middle layer? Or is this level of decentralization too little and more should be done as we go into this rethinking on devolution? Over to you, Mashiri.
Thank you, Arid. I think to me, more needs to be done. Because if you look at what was devolved, health was the most devolved functions. People are looking for more funding to be able to support more functions to be devolved. And even as we talk now, there's a debate between counties and national government on whether, we are in compliance with the Constitution, Schedule 4, on devolving all the functions. So I think what, to me, I think needs to be done is we look at our constitutions once again, even before we review the next constitution, ask ourselves whether did we implement the constitution the way it was? Did we devolve the functions the way they were planned in the constitution? Did we provide the funding to support those functions? And more important, did we support the counties to be able to, implement those functions in a way that it will not distort the services at the county level? So I think, to me, more needs to be done. I'll probably advocate for more devolution, but more guided devolution. As I said, we went for a big bang theory, and because of that, there was disruption. So I hope that as more gets devolved, I think there'll be time for people to sit down and ask themselves, what is the timing? What is the resources required to be able to devolve? What structures do we need to put in place to ensure that there's smooth transition? And more important, what capacity is required to be able to get the counties or as they take up more functions? Thank you, Arin.
Thank you. So let me take that thread and spin it a little bit further. And I want to go to Jorge with the same question. So Kenya thinks more could be done, or at least that's Mashiri's view, and I tend to believe him. But for Indonesia, it's a little bit more complex. It's not 47 counties. We're talking about 514 regencies and cities and more than 30 provinces. So you said, Jorge, in your presentation that resources for health may be mostly local, but seems authority is not fully local. So is it a question of accelerating that capacity development so that more authority can be truly devolved or deconcentrated? Or do you think this vast number and the geographical complexity of the country precludes further true decentralization? Jorge.
Yes, thanks, Arin. That is the million-dollar question in Indonesia. Authority, as you mentioned, I think that authority is sometimes present there, and yet at the same time, the key issue is that there is limited capacity at the local level for planning, for executing, for assessing performance. I think that, of course, accelerating capacity development is essential, and yet what we see in these countries that the small size and the vast number of local government sort of like impedes that to some degree. Indonesia is a widely diverse, it's an expansive archipelago nation. Besides the 17,000 islands, we're talking about 34 provinces, further divided in 514 districts. And many of them have very limited geographic scope, very limited capacity, very limited reach. And as Miral mentioned, sometimes finding, that the sweet spot can be challenging. The reforms to increase the fiscal transfer to the local level now under COVID, so those reforms have stopped, or let's hope that they're just being delayed or postponed. And depending on how COVID unfolds, it is likely that this fiscal transfer may be postponed indefinitely. This is, of course, unfortunate, mainly because I think that a debate had been opened. There was a debate ongoing with different entities voicing their suggestions and concerns regarding how the next phase of decentralization should take place. I think that the country is realizing that there should not be sort of like a one recipe suits all, and that so like the next phase of decentralization should take into consideration the capacity of each of those provinces and districts. It is the case that there's going to be a need to accelerate the capacity development, and as you mentioned, it is true that the sort of like the geographical composition of the country, as much as we would like that is not the case, it sort of like precludes that further development. Over.
Thanks, Jorge. That's certainly opening up a few different levels of complexity. So I have some very good questions already queued up, and we'll be going to them shortly, but I want to bring in our two discussants and especially Alison. But just before we go to Alison with a very interesting question that I've just thought up, Meral, did you want to come back in on the two responses that we've just heard? And I think on your formulation that decentralization can sometimes be too much of a good thing. So Kenya thinks that it's not yet too much, and in Indonesia, maybe more decentralization could become too much. So what do you think would be a good way to calibrate this? Are there any markers, indicators of administrative capacity or fiscal devolution that would act as kind of early warning systems? Where do you think that we'll know whether decentralization has crossed into impracticality and course correction is needed? Meral.
That is a really good question, a really tough question too to answer. I mean, I think that question of how much is too much decentralization is something that a lot of people are looking at and analyzing, and they have been actually for quite a while. I will say that, for example, when in the early 90s, as Eastern Bloc countries were transitioning and starting more self local government, there was this rush for every village declaring themselves as an autonomous municipality. And so you had this proliferation in countries like Czech Republic and Hungary and stuff, and really kind of a fragmented local governance scene, which over time has consolidated more and is consolidating more. So you're seeing a history where in countries where they quickly went very fragmented, some of them are kind of coming back in and trying to consolidate more in together. On the flip side, you have countries that are continuing, like you said, to wanting to get into smaller units. That sounds like the case in Indonesia. It's certainly the case in Nepal as well, that is looking at devolving to over 700 local governments, which for a country of that size is also those are very small units, and it raises those questions of how do you find the balance between capacity and efficiency. I will say there is no perfect rule of thumb on looking at what the right size should be. Different countries have different layers, of course, of government. So, but most developing countries you're seeing tend to have 2 layers, which is sort of a main layer like a province or a county or a district level. These call different things, and then a second layer, which is maybe a ward or a village level. Some of the research indicates that at the district level or the main level, let's say, there's a general population thumb that's looking at around 300,000 people. But of course, using population isn't a good way of making an accurate measurement of any kind, because 300,000 in a place like India will be a town, and it might be a vast territory in a different country. So, so really, we're most guided by the general principle of subsidiarity, which stresses that goods and services should be provided at the lowest level of government that can efficiently and effectively deliver it. So again, there needs to be some analysis around what allocative efficiency looks like, administrative capacity, some balance between that, and also issues of representation. Having local governments that are too large means more travel costs for citizens, and so in a poor country, that can have real effects on access to services if someone has to travel very far to get something, if the local government unit is far away from their home. So there are all these balancing points that need to be put into consideration. I think that, I'm a bit of a geek around civil service and administrative issues, as you heard, I could tell. I do think that issue of capacity. And so I think having the sufficient ability to devolve to where you have enough capacity in the local area to hire the skills that you need and to be able to manage things like data collection, things like those kinds of things, that's an important marker, rather than getting smaller and smaller. Smaller level might be good for things around participation and gathering information like village budgets and things like that, but perhaps at a higher level, a province level or a wider level, aggregating those and then making those kinds of maybe determinative decisions on funding or things like that. So there's different levels of way of being able to address the capacity and how much is devolved at like a ward or village level versus at maybe a provincial level, which would be a bigger unit. I should just say also that naturally our role is to support our partner countries in whatever central or local government structures exist, trying to perform at their best and most effective level. So we can engage in those discussions when invited, but I would just then talk about some of the trade-offs, I guess, between more or less decentralization. But yeah, no perfect rule of thumb, but I think the important points that are being made, Kenya looks like it has made those sort of decisions at that larger units of decentralization, and it looks like Indonesia going smaller makes sense from the geography of the archipelago, but definitely that adds a lot of complexity on from a capacity perspective.
Thanks, Meral. You put a lot of complexity into your response as well, and we appreciate that this issue is complex. It's a politically contested territory as always. So, Alison, I know you've been waiting patiently, and really need to get your response on a specific topic, but just because of time, if you could keep it brief, and I know it's hard with such a complex topic. So, we've been talking about elites here, basically government decision makers at the top level, at the central level, local leaders, but what about the bottom-up aspect of decentralization? What about the voice of communities? Do you see any promising practices that might enhance the practice of decentralization, that perhaps forge those relationships between the community leaders and their local governments and then forward into the central level? Over to you.
Yeah, thanks, Arun. Yeah, I would say, after decades of implementing decentralization programs in the health sector around the world, we're really learning, no shock, that meaningful public participation and these strong feedback loops are really difficult to achieve. On the public participation side, there are several key challenges to doing it effectively that can include political will, capacity, as we've been talking about a lot, and capacity on both the sides of government and citizens. Then there's the funding to implement any kind of public participation approaches or interventions, and then the inherent unequal power dynamics between citizens and governments, as well as levels of trust on both sides. Having said that, we're very fortunate that there are now countless initiatives around the world that aim to strengthen that link between governments and citizens in planning, implementation, monitoring to different degrees. Some are focused on planning and budgeting. In Kenya, for example, there's a mandate for public engagement in the health sector annual planning process, and how well that goes is, varies from county to county. On a more, specific level, you've got the motion tracker, which is now being used in several countries in Africa and Asia to engage civil society to work hand in hand with willing government partners to elaborate on, better understand, and take action on family planning and reproductive health commitments in a coordinated fashion. Nigeria, of course, is a site of multiple different approaches. In several states, they're implementing town hall meetings to facilitate community dialogues around the Basic Healthcare Provision Fund. There are also multi-stakeholder coalitions to monitor, review, and use evidence to improve maternal neonatal child health outcomes. And so those are just a couple of examples linking community with their local governments. Feedback loops between local and national governments are obviously a whole nother level. And I think, as everyone was talking about before, the added complexity really makes that difficult, and that communication between those levels is really important. I think we have talked about the disconnect in roles and responsibilities, not necessarily understanding roles and responsibilities within the decentralized system. And just to keep it brief, I think ultimately, for both the relationship between communities and governments and between local and central governments, there almost needs to be a cultural commitment within the governments and within society to prioritizing these exchanges and these networks and these communication linkages and valuing the information generated from them. And from my view, I think that's something that every single country struggles with.
Thanks, Alison. So let me now turn to the questions that have come in. And I'm going to take two questions and try and roll them into one. They're about Indonesia and Kenya, but sort of around a central question of whether decentralization is adequate to handle the technical innovation and change that comes with the health system. And I mean, if you look at COVID-19, and the next stage will be hopefully a vaccine, rolling that out, appropriately planning for it, or even changes that might come to specific vertical programs. If you think about rolling out such technical change, how do we navigate the role of central authority versus a very vast and possibly diverse periphery? So let me ask that question first to Jorge, given that it might be more intense there in terms of disseminating such technical guidance. How do you think it works in Indonesia? Does it work well, or is this one of the inherent limitations of a true decentralized system?
Yes, hi, Rick. Can you hear me?
Yes.
Yes, I think that's what we're going to see happening over the next few months. I think that in the specific case of Indonesia is where the constraints that we are seeing in terms of local capacity are going to be quite stark. And I think that the COVID situation is sort of like an opportunity for all of us to see some of these limitations, sitting on a first row. I mean, just in the case of Indonesia, when the pandemic started, they set up a task force, and this task force was a National Economic Recovery Committee task force or something like that was supposed to be handling the the reconstruction in all the efforts to battle and tackle the pandemic. But from what we're seeing is that what is actually happening is a removal of authority at the district level, towards the central government. And what this is actually causing is that the central government is focusing more of its recovery efforts on the economic sector and less on the health sector, or less on social protection. And we're going to see how that unfolds, especially now in in an environment where we're seeing that at least 3 million people in Indonesia have lost employment, and this is only among the formal sector. I think that the figures of the informal sector are about 4 times that. So I don't know if that answers the questions, but I'm going to stop there.
It's a good starting point, Jorge, and I think we can discuss for a long time on these issues. So Mushiri, if I may just take that thread on the role of local governments in a complex health system delivery landscape where technical guidance changes. There's a question here about whether, really looking back and looking at all the change in health system delivery that has been happening sort of neutrally outside of decentralization context, do you think counties have done well enough to deliver results, really bring down some of those indicators? And also, just looking forward, you mentioned the constitutional architecture and a process of review and change. Could you maybe think ahead and give us some ideas on what this might hold? Over.
I think let me start with the constitutional architecture that this is a political process. I think we have a task force that is collecting views from the public on what areas the public want amended in the new constitution. We haven't got a grip of the full report. We are hearing pieces here and there. I think one of the pieces we are hearing is that they want to expand the top to be able to accommodate more players. We are hearing that they want to centralize human resource for health to a commission or an authority. As I said, this report hopefully will be, if it were not for the COVID, this report would have been out. So I don't want to talk on something I've not seen. Rather, I wait until we get the full report and can be able to comment on it. But let's discuss that one once the report is out. In terms of this COVID and counties capacity, I think COVID has brought some opportunities in the sense that we are now seeing more cohesion between national and county government on managing of the COVID. We are seeing national government taking more responsibility in terms of providing guidance on how to manage COVID situation, and counties doing more of service delivery. We are seeing national government being the mobilizer of resources and pushing those resources to the counties, and counties putting the infrastructure to be able to manage the COVID. It's too early in the game. We are now at 18,000 cases so far. We'll see how things go, but I think it has created an opportunity where counties are appreciating that we are there to deliver. We need to put structure systems to be able to manage those cases, and we have to listen to the guidance coming from the national government if we are going to deliver. So that opportunity is coming up, and I think so far we have done very well in terms of management of the COVID. There are pockets where the numbers are still moving up, and we hope that with this cohesion between county and national government, we should be able to pull together through these challenging times. Thank you.
So I want to go to Alison. Thank you, Mushiri, for a very quick soundbite and maybe a closing thought. So, we've seen, at least in the Kenya case, that capacity has really come up, and resources, well, they're almost matching up with the functions, but not quite there yet. But do you think as capacity increases at the local level, at the county level, counties will also rethink their relationship in terms of health system governance with the community, with the population, and really almost a capacity for accountability and for voice also rising alongside political and fiscal devolution? Or is that a dream too far? Alison.
That's a really great question. And from a governance perspective, I'm always clamoring for more attention and more focus on those accountability questions, especially at that local level. And given the promise of decentralization, to bring government closer to the community. And I think it does require a very specific skill set at the local level to really engender that, as I mentioned before in my other remark, about that culture of valuing what feedback from citizens can bring into the process. And so I think we're seeing some movement in that. Nigeria, for example, in the FCT, they have established a line item for a civil society network within the FCT budget. I have yet to see whether or not it's going to be funded, but those kinds of initiatives I'm really fascinated by. We've seen a lot of work in Guatemala on this. Throughout their health sector decentralization rollout. So there are pockets of it that are happening. So I don't think it's a pipe dream. I do think it requires a lot of political will and political commitment and a lot of good faith on all of our actors, on all the stakeholders' parts to really work together through these complex policy programs and just all these really interesting questions that are facing people.
Thank you so much, Alison. As always, politics matters, the vote matters, the voice matters. And I think the more communities get engaged, the better will decentralization work for them. I want to thank all our presenters today and certainly all our audience members for all their questions. I think you've just seen the link for where the webinar recording will be posted. It should be available fairly soon. Please do come in and check that out. And if you have questions or you would like to see the presentations, please send us a note. And thank you so much. And I will close our webinar here. Have a good day everywhere that you are. Thank you.